Today we're going to talk about this stroke and dysphagia. A lot of patients in the ER, when they come in, they're always saying, why do I need to see speech therapy to start before I can start eating, right? That's one of the things, like, I can speak, why do I need speech? So speech therapy, we're also known as speech language pathologists, right? We're part of the rehab department with PTOT. And we cover speech, language, cognition, voice, swallowing, so anything from the neck up, essentially. So that's why we work with patients with trachs and speaking valves and that sort of thing. So we work with anything with the brain. So it's just a quick introduction. So the role of the speech pathologist is to work on the safety of the patient. We're trying to eliminate aspiration, determine their safest diet for them, and monitor them over time, because with strokes there is a large percentage that do recover from having dysphagia and are able to improve and get back on a regular consistency. We also work on efficiency, making sure that they're meeting their caloric intake despite having the dysphagia, minimizing their fatigue. Then there's different kinds of assessments that we do. At the hospitals, we do the bedside clinical, but we also do modified barium swallow studies here. And fees, this is one of the things that we do with the laryngoscopic exam, but it's not available at Castle right now, but we're hoping that it will be in the future. So here are some MBS fees examples. So this is a good quick video. So normal swallow, it should go down to the esophagus and not the trachea. And here's what we look at. We put barium in the food, different textures, and we watch them swallow. So it's really smooth going in, going down. The next one, a little bit of delayed swallowing, where the bolus is already deep into the by the esophageal opening, and then some of it is entering the trachea, and then there's some pooling. So that's one of the things we do, but we do it with different textures. We also try to prevent aspiration during the study. So if we see a patient's aspirating, then we determine, like, can they do strategies? Like, if they're cognitively intact, we want to teach them about maybe a chin tuck. Some chin tucks don't work for everyone. I know there's a myth that, oh, just have them tuck their chin and they can swallow. Sometimes it causes more aspiration, actually. So it all depends on the patient's physiology. And so we do try to determine the safest swallowing consistency that they can do. And we try to minimize the use of thickened liquids. Like, if we can, we want to get them on thin liquids, even if they have to do a strategy. Just because there's no substitute for water, right? So here at Castle, we do have a process where the code stroke is called. Typically, they should generate a consult through the MD order set of the stroke order set. Sometimes it doesn't, but it really begins with the nurses, with you guys, doing the RN swallow screen, especially before giving medications. And so how does a nursing swallow screen differ from the bedside evaluation? The swallow screen for you guys, you have, I think, Norma's going to go over it, but you're basically just testing water. It's a pass-fail. It's a dichotomous outcome, right? If are they coughing, are they having all these other symptoms, and then you can say they passed or they didn't. But the focus is really just getting their medications in, and in the ER, not really worried about a diet yet, right? It's just really, can they take oral medications? Can they have water, so for oral comfort? For the bedside swallow, we do different consistencies. We really look at the whole types of different textures, because we want to get them on a diet for oral nutrition. We have a little bit more of a nuanced interpretation, because we're looking at the big picture. We're looking at their histories. We're looking at their fatigue level, their mentation, if they're able to feed themselves. Their risks of aspiration is confounded by their ability to feed themselves, also their respiratory status, all those different things that impact the eating. And they're eating usually 30 minutes at a time, and so in that time, different things could change. So we're looking at different nuances of the swallow. And we're also looking for, can they do strategies? If we teach them or adjust the diet, will that help them be safe, and that way we don't have to keep them NPO? And we're also looking not just for medication and how they're swallowing that, but also for the nutrition. So with an ischemic stroke, there are a lot of MRI-based neuroanatomical predictors, definitely for dysphagia, aphasia, and dysarthria. Anything with the brainstem stroke, that's the seat of that's the center of our swallowing. But the swallowing involves more than just the brainstem. It actually involves different processing and planning of the swallow, and sensory. So some of our patients that have like a large vessel occlusion, like what Kimberly was saying earlier, a lot of those patients will have some swallowing issues because their sensory is impaired. So the larger the stroke or the vessel that's involved, and the higher level of the NIHSS scale score, the more likelihood that those patients will have dysphagia involved. I noticed that when she presented the slides of different anatomical, and they were talking about aphasia and that sort of thing, dysphagia wasn't written on there because it's not just localized in one area. It's not just in the brainstem, but throughout the brain. And the elderly people, the brain atrophy, increasing age is actually one of the predictors, because as we age, we're actually using more of our left and right hemispheres to trigger the swallow than when we're younger. They're finding that when they're tested younger swallowing and where it's triggered, they're activating both parts of the brain. But as they get older, and you have more atrophy in the brain, or the white matter and cortical changes, then the swallowing gets impaired. So brain atrophy in increasing age is one of those predictors for dysphagia, no matter where in the brain the stroke is located. Procedures for the swallow screen, you want to position the patient upright in bed, provide oral care. We're putting that there. I know it's like second, you kind of know that, but you don't want to have a lot of false positives, right? You want to prepare the patient for the screen. Sometimes their mouths are so dry that they cannot barely move their tongues, or sometimes when we're getting patients from the sniff and their mouth looks horrible, right? There's gunk in there. Try to clean that out first, because if you try to do the swallow screen on a poor platform, right, then you might make them aspirate unnecessarily. So prepare the patient, position them upright, and do oral care. Swab their mouth, make sure it's moist, and then give them do the observational screen and the swallow screen. You can probably do the observational screen while you're doing the simple oral care to get them ready. And the swallow screen, there's two different kinds out there that are validated for nurses to do. There's a 3-ounce water, but the Yale protocol, which is using 3-ounce water screen also, is the one that has the highest sensitivity and specificity for detecting dysphagia. And it's 3 ounces of water, and you have them drink it, just drink it all at one time. That's the Yale. And sometimes some patients are not able to do that. It doesn't mean that they're failing, right? But try to see if you can have them self-feed and just tell them, okay, drink this entire 3 ounces of water, and see what they do. Because their ability, their swallowing intact, being intact with their swallowing has a lot to do with that ability to coordinate the swallow and swallow sequentially. And so they pass if there's no throat clearing, there's clear vocal quality. Have them say something like, oh, was it good? Or say, ah, or anything to just trigger them to voice. And then make sure, their vitals, that they're not dropping. Usually with O2 sats, if they have a stable O2 sats and it drops by greater than 3% change, then that is another trigger for the Yale swallow. So if they fail, if they're coughing, their throat clearing, there's any change in vocal quality, if you're noticing any kind of decline in respiratory status. Some of the patients will say, oh, I'm having a hard time breathing, or I have to catch my breath. So that could be an indication. What if the patients fail their swallow screen? What next, right? So you have them be NPO, request the SLP eval. Your documentation should trigger an eval from us. We are staffed 7 days a week. I know one of the questions was about in the ER, can we call SLP to come down to the ER? You can, as long as it's within the time frame that we're here. Sometimes when the census is low, they tell us to go home if there's no patient to see. So we're not here till 5 p.m. or 7 p.m., but sometimes we might be. If the patient requires urgent oral medications and we're not available, consider IV meds. You can trial giving them applesauce, crushing it. Applesauce is less, there's more, it's slower to go through, so some patients can manage that better than thin liquids. So try to avoid thin liquids as much as possible, because it just shoots down really fast.